Hello, everyone. Welcome. Lots of names that I recognize. Hi, everyone. If you're here for the Eras Tour movie, you're in the wrong place. But if you want to learn about sensory motor OCD, you're in the right place.
Which Rotten Tomato, it's similar scores on.
Not saying you weren't our first choice, Dr. Kamenetz. Just
Right.
saying that Taylor Swift has a busy schedule. That's all I'm saying.
Her speaker
Uh,
fee just way too much.
it
It's
was
unreasonable.
a little out of the SCPA budget, but we'll
Okay.
do anything for our members. So I'm working on it, guys. I'm working on
Yeah.
it.
We could fundraise,
Yes. I just got to find the right one. Uh, all right, we are going to go ahead and get started because there are some really interesting things for you to get to. So welcome, everybody. I know we usually do our workshops here on Friday night, so welcome on this Thursday night. We are glad to have you, and we are very glad to have Dr. Elliot Kamenetsky. Am I pronouncing it right? Hopefully.
Nailed it.
All right, fantastic. And he's here to talk to us about sensory motor OCD. Dr. Kamenetsky is the founder and director of My OCD Care and the Center for Child Behavioral Health, practicing in New York City and Northern New Jersey. He holds a PhD in clinical psychology from Hofstra University and completed his postdoctoral fellowship at Northwell's OCD and bipolar centers. Dr. Kamenetsky's postdoctoral fellowship prepares candidates in both attaining clinical expertise and the business and administrative skills necessary to start their own practices. And your students are very lucky to have that last part as well.
Yeah.
So without further ado, I'm going to turn it over to Dr. Kamenetsky. If during the presentation you have questions or comments, there is a Q&A button at the bottom, and I will pass along your questions to our presenter. At the end, I will give you information about how to get your continuing education credits if you signed up for those. And so just make sure you stick around at the end. And of course, there will be time for questions at the end. So without further ado, Dr. Kamenetsky, welcome.
Thank you. And thank you for that kind introduction. And if you do have questions throughout the talk, you could just, ask them. And if it makes sense to weave them in, I'll try. But my talk and the slides look, you can see the slides or the opening slide? All right, great. So my talk today is on sensory motor OCD. And it's a subtype of OCD that is not so common. And I think one of the challenges about it is that there's not a ton of research on it. But we'll get there. Okay. So just as far as disclosures are concerned, yes. Hold on. Yeah, so I'm the clinical director of My OCD Care, which provides treatment for sensory motor OCD. So I just went to a conference and they discussed like the whole concept of what you disclose. And sometimes people are just like only talking about financial interest, but there's a lot of other interests. So like I do provide treatment for this disorder, so just keep that in mind. But aside from my professional affiliation, I have no direct financial conflicts of interest to disclose in relation to the content of this presentation. Big Pharma did not call me yet, but we'll see. Okay. All right, so agenda. So I'm going to describe sensory motor OCD. Then I'm going to discuss similarities and differences between sensory motor OCD and other presentations, like more commonly known presentations of OCD. And then I'm going to discuss the research on sensory motor OCD. And I'm going to discuss my clinical experience and lived experience with sensory motor OCD, and a kind of like self as case study type thing. And so while I could be hesitant to use, like I'm very much evidence-based treatment guy, and I really like everything, all my work to be informed by, what does the data show? I'm also not a robot, but I really like to be data informed by my approach. But sometimes there's not a ton of data in an area. So, you use both, things that are supported by data and your clinical wisdom and also your personal wisdom. So I'm going to discuss that. Um, I'm going to discuss my pet theories on why it's hard to treat. Um, and it's going to include the prospective memory theory and ameliorative, what I called ameliorative motivated acceptance versus values motivated acceptance. And I think both of these things could apply to other forms of OCD. And in the topic of values motivated acceptance, I'm going to talk about, discussing finding one's value, meaning, purpose, and mission, which usually doesn't take less than 2 hours. So I think we'll be able to do that. All right, get excited. Okay, awesome. All right. What I just clicked. Yeah. Okay, what is sensorimotor OCD? Great question. So it's called a number of terms. Some people call it somatic OCD, somatically focused OCD, hyper focus. These are all ways to describe this phenomenon that people have that's extremely distressing. So it involves heightened, uncontrollable attention to body sensations like breathing, swallowing, or the rhythm of the heartbeat. This can be extremely disruptive and distressing, especially because the trigger is within you and you fear it will last forever, right? So, very, very, so people who work with a lot of OCD, oftentimes you'll find that everyone comes up with their avoidance strategies, right? So, for example, a POCD case may purposefully walk a different way to their job that doesn't walk past the school, or so you could have like these strategies that could, at least in the short term, be effective in ameliorating the distress. But when the source of your distress is something that you cannot avoid, that adds a certain layer of torture to it, right? So like you can't not like all of these various all these various bodily what sort of parts of you, right? Swallowing, blinking, bodily processes. They're involuntary by their very nature, and they're just there are things going on around in our environment all the time. We're getting millions of sensory inputs all the time, and we integrate them nicely into our experience such that we could move through our world and live our life, right? And our mind takes the relevant ones and manipulates them and filters it into our consciousness, and we're able to then do what we need to do with that information. But when you start to notice things that are kind of irrelevant, right, things that are supposed to be on autopilot, like blinking, and you start noticing it, that could be very distressing, right? Because it's kind of like you keep on getting this irrelevant information, and it's almost like it people describe it as it really pulls you in, and it's so uncomfortable that's your relationship something with something that's so constant and within you, right? So like so when it comes to swallowing and blinking, I find very often the fear is like I'm noticing something that shouldn't be noticed. And when is that going to stop? Right? Like I need it to stop now. Like I shouldn't be thinking about it, and it needs to stop. When it comes to breathing, there's some other presentations of sensorimotor OCD. One is called pseudodyspnea. I may be mispronouncing it. but there's no organic explanation to it, or no known organic explanation to it, but you feel like you're not getting enough air. And I think what it's understood is that, kind of like the thinking about it itself and analyzing whether or not you have enough air, like, gives you a certain sense of breathlessness, or you're analyzing the saturation of your blood, or your lungs, whatever it is. So, like, you get this very uncomfortable feeling, and that's also one that I had. I think sometimes when, just like with many OCD themes, they cluster, um, and they could jump around. So even within sensorimotor OCD, you'll find people who notice blinking and swallowing, or swallowing and breathing. So I had a swallowing, breathing, and a little blinking. But I didn't have the question of, did I not have enough air? It was more of, like I actually felt like there wasn't enough air and there was no organic causes. And I realized, it was part of this presentation. But sometimes when it comes to heart beating, it's very much like, A, there's just noticing it, and B, there's like, if I don't notice it, will it impact it? Will it cause me to die? Is it these are the intrusive, fearful thoughts. Is it going to, is it going to stop? Is it the right rhythm? And there are, like, kind of like different offshoots to it. So for example, swallowing, sometimes people will have a fear, like almost like a tinge of social anxiety. Like, if I swallow when I'm just talking to someone, um, then I'll come off as anxious and they'll think I'm nervous and incompetent, right? And when it comes to the breathing slash heart beating, sometimes you'll you'll wonder. It can have kind of like a health anxiety type presentation, where it's like, is my heart beating the right way, right? But I think, like, in essence, the sensory motor, the hyper focus OCD presentation is really the irritation from noticing something against your will, without without wanting to do so, and it's really uncomfortable, right? So it's the noticing itself that bothers you. Okay, so research on sensorimotor OCD, there's certainly no clinical trials of people comparing various treatments to a group of individuals suffering from this presentation. There are some case studies, in my understanding, but the question is whether or not you could totally apply the research from other forms of OCD to this. And I think that that's a question, because on the one hand, there is similarities to OCD, which we'll go through, but there's also real differences, right? And so, like, even as it pertains to OCD subtypes, there are research on OCD subtypes which demonstrate that not all subtypes are the same, right? Like, so the DSM, for example, doesn't have like separate categories for the different subtypes, but we as clinicians speak about them a lot. So there's no, like, moral scrupulosity in the DSM. You know, there's no, there is health anxiety. But as far as, like, the OCD, which is certainly related to OCD, the DSM is basically like a big mess in terms of how they categorize things. So I definitely don't see it as our Bible, but I think it's just important to recognize that the subtypes themselves, even though we speak about them so frequently clinically, they're not in the DSM. However, there is still research on specific subtypes. Like, for example, Dr. Jed Sieve from Swarthmore he does a lot of research on moral scrupulosity, which is a subtype of OCD. But there's different response rates to um, to exposure and response prevention. I believe he found. I hope I'm not misquoting him. If he ever sees this recording, hopefully he'll correct me in the comments. But yeah, there's a different response rate to ERP other than other documented response rates. Potentially, it's because scrupulosity. Maybe the core fear is something that's so untestable if it's going to hell, right? Like you can't really make that determination or learn that that's not the case from all your, saying prayers without the right intentions. No way to test that out. So I think with sensorimotor OCD, I think it is. I think it's worth really researching, because if you go on Reddit, and you'll see a lot of various forums for individuals who are suffering with this, and they suffer tremendously. And while we do have, I think there is good treatment for it, and I think we'll discuss that more. But I think it's really worth researching. Like I said, there's no RCTs on the subtype. If I'm wrong, please let me know in the comments ASAP. But as far as I know, there is not. And I think it is unique enough from other subtypes to warrant research. Yeah, so that's why I'm going to give myself the personal license, in this talk, to, so even if there's no like clinical trials on sensorimotor OCD, there is research on mechanisms, so the discussion I'm going to give is going to be based on research-informed mechanisms. Some of that research is my own, so it's a teaser, and some based on my clinical experience, personal experience, and yeah, so let's see how this goes. Okay, so basically the cognitive behavioral cycle of sensorimotor OCD, there is a similarity to other subtypes, right? So I think like if we look at the classic cycle of OCD, I think you could understand it in terms of that type of cycle, both in terms of how it's acquired and how it's maintained. However, like the question is, are we just smushing it into this, or is there potentially a better way to understand it? But I think like it's a workable understanding in terms of the cognitive behavioral cycle of sensorimotor OCD. So we all swallow throughout the day, while we're eating and while we're not. It is a reflex, and if you notice that when you swallow, once you start, you can't stop midway in a swallow. It finishes on its own reflexively, right? So we all swallow throughout the day, and usually, like we're swallowing saliva, we're finishing lunch from earlier. So swallowing is pretty regular, just as is blinking and breathing, and our heartbeat. It's all these things going on all the time. And sometimes we're aware of these things, and it's a totally neutral experience, right? Outside of this clinical situation, right? Like you may just notice, that you swallowed. Maybe you swallowed, it's usually for a reason why you would notice it, right? Like maybe if you were eating and you swallowed and went down the wrong pipe, you may notice that. But generally, you won't notice. And if you do, you won't ascribe any meaning to it. And it's similar, and this is the appraisal model of OCD, which, recently, people have been starting to talk about inference-based CBT, which is interesting. But this is based on the classic appraisal model of OCD. Right, so you have this neutral stimulus, swallowing, and just being aware of it. But then it's like the appraisal of that stimulus, right? Like, why did I notice that swallowing, right? Like, so there's a lot of cognitive components to it, right? So I just noticed my swallowing before. Why am I noticing it again? And your relationship to that objectively neutral stimulus changes over time, right? So like in the beginning of it, let's say the first day you ever get it, it might just be like, oh, that's weird. Today I'm just noticing my swallowing a bunch. Like, okay, fine. But then like a week, you have it for a couple of days, you're like, what's going on here, right? Especially like for people who don't know what it is. And I think it's very important to both talk about this presentation of OCD, because I think it's very not well known. Because when I talk to people about it, because I wrote this article that people seem to like about it, about my experience with it, and what was helpful for me, I what's it called? Yeah, what was helpful for me, I totally lost my train of thought. Okay, fine. So we'll go back. I'm probably going to remember it. If I seem a little scattered, it's because I am. It's been a pretty difficult week. But okay, just getting back to it. Okay, so you have the, oh, now I remember to say. Yeah, so I think you should tell people about this form of OCD, because some people have it and they don't even know what it is. And they just think that it's like just something that just bothers them and it's annoying and they keep it to themselves. Also, I find when I talk to therapists about it, they'll say, like, wow, I had patients who spoke about that to me and I had no idea what it was. And I just told them to meditate, right? And it didn't help, right? Or something like that. So yeah, so I think it's important to talk about this and other forms of OCD. And not ironically, but luckily or auspiciously, it's OCD Awareness Week. So this is going to be my awareness effort. All right, so like, so back to the appraisal of that originally neutral stimulus, like you'll be like, oh, that's getting annoying, right? Like, so I'm trying to just focus on something or do something, and then my focus on something is getting interrupted, right? Like that's annoying. Like, when am I going to stop, right? So it goes from something that is annoying and to like something that's painful, then to something that's extremely painful. And then when you think about that extreme pain, like not ending, that becomes like, you could really despair. So, so I think, our cognitive interpretation of it is very important. So I mentioned before, like sometimes there's a social anxiety component when it comes to the swallowing, and that could potentially, when you think of like how fears are acquired, like what makes it go from the neutral stimulus to the conditioned stimulus, like the fear conditioned stimulus, how is that paired? So for me, this might be a little TMI, but what can you do? So I think the original pairing was in the social anxiety context, where when kissing, I would notice myself swallowing, right? And I was wondering if she would notice, right, and think like I'm anxious or something, which I was. But okay, so like I started noticing it in that context and like thinking like, oh, I should how much should I be swallowing? How much are you supposed to swallow in this activity, right? And so then I just started like thinking about it. A, because I wanted to not do it so much. B, because like I was curious, like what is it supposed to be? So I just started noticing it, right? And I think that's was like my personal acquisition of that fear. Um, so then, once you're starting to notice it, like the noticing itself becomes like really difficult, right? And so the emotion you'll feel is anxiety, like a very awful feeling. Um, yeah, so then like naturally, when you're feeling awful, you try to not feel awful. So the compulsions will include wishing it away. And this is something that Dr. John Grayson talks about. It's called the wishing compulsion. And the wishing compulsion is kind of like when you are wishing things away, right? So he described like, which applies across the board in a number of OCD, where like, kind of just when you're getting an intrusive thought, like kind of just like wishing it away, assessing how much you're enjoying a particular experience, and um, and kind of just wishing it were better, comparing how much you'd be enjoying something if you didn't have this symptom, and it's kind of like this constant wishing. And I think um, it was a very helpful you know way to understand the compulsion that people don't talk about a lot. um, Trying to stop noticing it, which is always you have the white bear problem of if you stop trying to think about a white bear, you'll think about a white bear. Um, so that's a compulsion. Distracting for the sake of not noticing it, right? So that's a big one. So distraction could work, right? And also distraction cannot work when it comes to um, compulsions. But I think when you're distracting for the sake of not noticing something, I think you tend to notice it as well, right? So you're like, I'm gonna listen to music or I'm gonna go out. And sometimes you go out and like things get exciting and there's like, I don't know, ambulances outside and you actually genuinely get distracted. And then maybe you're doing something fun and you're actually get like good distraction. So I think not all distraction is the same, but generally, when you like kind of play, I'm going to distract myself so as not to notice something that's gonna be there, like you're swallowing and blinking. It tends not to work. So there's a lot of checking compulsions, checking like, oh, in the past 5 minutes, how many times did I notice it? Um, you know, Checking the rate of it, checking, am I watching? Um, am I checking it right now? And you do get like a certain, like, patients also describe like a certain rush they feel when they're like, oh, I haven't thought about this for 5 minutes. Or, oh, wow, I haven't thought about my swallowing all morning. Like, oh, crap, I'm thinking about it. Right. So it's like, compulsions are always reinforced. And that's why you keep doing them. So I think there's a certain like celebration of those moments where you're not doing it. So you kind of keep on checking. But it's not a ton of relief. Sometimes it is, sometimes it's not. But intermittent reinforcement is pretty powerful. A big compulsion will be reading about swallowing, and that, or reading about A, what swallowing is, and B, um, yeah, so what swallowing is, and also people who have this problem. And I will really recommend, that if you're dealing with this problem, don't read message boards of people who are dealing with this problem, because the people who are writing on message boards about this are often in a really bad place. And I thought I was doomed to eternal suffering based on people who've been dealing with this for years. So I'm like, oh, the course of this is for many years, obviously, and it's going to be terrible. So, like, I would, keep that in context for if you're working with someone who plans on reading that stuff or may already be. Individual experiences will vary. So drinking is a big one. Or like, let's say you're noticing you're swallowing, you may purposefully drink something. because when you're drinking something, it feels like a more natural swallow, right? Like it's really annoying because sometimes also altering your swallowing, right? So, you know, maybe swallowing a bunch of times, because if I do it enough times, then I won't notice it as much. Um, and yeah, so these are all various compulsions, and they're all, trying to control something that's out of our control, which is, so true in many anxiety situations. And you'll feel some relief sometimes, sometimes not. Um, but you'll feel, even if in the times where you do feel some relief, you'll notice the swallow again, and then you repeat the cycle. So it does follow a similar path, or it does share that similar cycle as OCD. And also, it's different. Um, hold on. I
Dr.
wonder if
Kamensky, we have a question, if I
yeah,
can
sure, please.
for a quick second. One of
Yeah.
our participants asked, could someone who is aware of their muscles clenching internally throughout the body be a form of it? For example, they worry their awareness of it will never go away. They also have a
Yeah.
muscle spasm in their eye and worry about the discomfort, awareness it causes all the time, despite any medical etiology for both of these things.
Yes, and I'm just gonna find a working pen so I could. Okay, here we go. Yeah, so I'm really glad you brought that up, because there are I just like gave the most common ones, but there's so many. And I think when it comes to any kind of OCD presentation, anxiety presentation, any presentation, you're doing like a really careful functional analysis. You're doing a really good case conceptualization and a treatment plan based on that, right? So, so it sounds like you ruled out the medical explanations. And if there's any kind of uh, internal or even external uh, situation where you're bothered by noticing something, then we're in this territory, and maybe there's even some overlap with misophonia, right? So where it's like you're noticing the sound of other people chewing, right? And it is really, it has this awful effect. And I don't know if there's like any type of research established connection, but like noticing things you don't want to notice is very difficult. Sounds, that's an example of sounds. So you gave an example of like muscle twitching. Yeah, 100%. Like people notice muscle twitching. People notice a particular part of their body, and some people describe this whole category as neutral obsessions, because like if it was a fear of dying of AIDS, you know everyone understands that, why that would be scary. But like thinking about a body part, the content itself is kind of neutral in nature. So it could often be misunderstood when you're thinking about neutral obsessions. So certainly what you're describing could be, could fit very much into that. I've worked with someone who, has a particular part of their body, um, like let's say a freckle, right? And they just keep thinking the word freckle, right? Thinking about a particular freckle on their body, right? So, is that sensory motor? It's certainly hyper focus. Some people refer to it as an earworm, right? Because it's just like this thing that you just can't stop thinking about. I've worked with someone who kept thinking about the word glasses, right? Just that word for whatever reason. And I once had an earworm with the word toaster, right? I was camping and I thought about a toaster, because what else would you think about while camping? And then I'm like, I'm going to think about this word forever. I don't know why. So I think that's certainly could fit into this. Did I answer your question? Was that helpful?
It was from one of the attendees, so I will
Oh, okay.
answered unless I see another question that follows it.
Right. I think this is my first
She said, "Thank you
lecture
so much."
without an audience. I usually like you know, okay, but it's fine. I'm gonna work through it. Okay. So okay. So just like we have the understanding of the acquisition of the pairing of the noticing and the anxiety and the how it's maintained, similar to OCD, we could understand how to uncouple them. And ERP is a great way to uncouple intrusive experiences and fear, right? So, you know, and this is an effective treatment, ERP, for this, in my experience. If we had this awesome, well-powered RCT to demonstrate that, that would be awesome. But until then, I think it's fair to, a lot of the RCTs on OCD is a lot of them are about contamination as a subtype, and less so on other themes. Um, so we are, left to, so we have like the RCTs establishing that this is a useful intervention, and then kind of like the clinical community discusses, like research ends at a certain point, and the clinical community collaborate on on trying to troubleshoot. And gives me, I think this is a good time to give a shout out to, if there's any OCD anxiety specialists in the crowd, there's an awesome Facebook group I call OBS. I'm the only one who called it that. But it's the OCD anxiety BFRB specialists. And it's a really great group. And people get to ask questions about it. And you have like the leaders in the field just, making jokes in there. It's awesome. So if you do specialize in the area, it's definitely, or even if you're learning to be a specialist, it seems like there's a lot of people there. So check it out. Okay, so so people adapt ERP like other subs to treating it, right? So basically, you'll purposely expose yourself to anxiety-provoking stimuli in the exposure. So some people will suggest post-its, right? So like, things that purposefully make you notice it. And as such, it's really like this leaning in, it's really this leaning in process, right? Where, you're so set on not noticing something, right? You're really doing opposite action here, right? You're purposely reminding yourself of it. Okay, so like maybe you'll put post-its around the house with swallow on it. Maybe you'll put like this reminder on your phone. I think there's an awesome app called Yapp, YAPP, which just sends you intermittent reminders of something throughout the day, and you could control like how many times you're seeing it. So it'll just be like, for fear of death, it's gonna be like, oh, you're gonna die probably in 40 years, or something like that, and you'll just get random reminders. So your random reminders, if you're treating this in someone else, it could be like, did you just swallow, or something like that. And in doing so, you're really helping to, just allow people to notice something, back, in a way that's not associated with fear, welcoming it in instead of pushing it away. And it is helpful, and it's helped a lot of people who I've worked for. Recordings are helpful, like if you have a 1 hour recording, and you are, let's say, every couple of, every minute or so in different intervals, you're like, oh, are you swallowing? Right. So like trying that out. And in doing so, you are, you are going to, help reduce the anxiety associated with the noticing. And you allow yourself to feel anything that comes up without resisting, right? You are, you're not trying to monitor. You're not celebrating the absence of it. You're not reading articles about it. You're trying to do nothing, right? You're just doing the noticing, right? But without the things that you do to try to control the noticing, right? And that's what we call response prevention. Uh, then you stop doing all the aforementioned compulsions in day-to-day living, right? So response prevention is throughout, right? So there's kind of exposure where you have the planned, practiced exposure, and the response prevention, which is the planned, not doing compulsions in the context of that exposure. But then response prevention is forever, right? We always don't want to do compulsions. So so that is effective, and people use different types of tools. I put mindfulness there. That's not like a relaxation strategy. People find mindfulness very triggering if they have this condition, right? Because you really don't have a lot of distractions. So like if you don't like noticing your breathing, what's like the most basic mindfulness activity? Let's notice your breath. Notice it rising and falling, right? So people can find that very triggering. So like opposite action is like do your mindfulness. And this brings up this interesting topic of like, is mindfulness a totally neutral treatment, right? Is it a totally neutral act? And I think people, I think like some research shows it's a helpful thing to do. Other research shows that there may be individuals who don't do well with mindfulness. And I think like, people suggest it in a very, free flowing way. They'll be like, oh, just, try Headspace. But there are people who do not do well with mindfulness or meditation in general. And, so I think when people do recommend it, it should be, kind of focused and thought out. Okay. So basically there is, like other ERP, like other OCD categories. There is, it does line up. I think it's not perfect and it's not the same as how you would treat, contamination OCD, where this, the stimulus, like you have it right in front of you and it's very tangible, right? Because sometimes noticing you're swallowing isn't triggering and sometimes it isn't, and that's fine. Even with exposure, there are certain things that are sometimes triggering and sometimes not. But it's not so, so it does work, but it's not perfect, right? And I think okay, so what are the results of ERP4 for sensorimotor OCD is tough to say, because without research we can't know for sure. But informally, many people benefit from it. Some benefit somewhat. Some benefit a lot. Some people don't benefit at all. And I would say, like, there, in my experience and in talking to colleagues, there is a certain like ebbs and flows, right? Like, like the maybe the sensitivity to the sensorimotor OCD, it could be good, but I think in terms of the frequency, intensity, and duration, maybe the duration between episodes will be shorter, right? Than like, because like maybe in other forms of OCD, kind of like they will, yes, flare-ups happen, of course, but oftentimes I find like once they get the skills down and there's kind of like they take the thoughts less seriously. Yes, like new themes pop up and sometimes there are flare-ups even within the theme. But I do find like they could get a certain sense of like past it. And with this, I found like sometimes people do, but maybe a little bit more of like there not being like this steady amount of time without it. And I wish there was more research to see how maybe the results that you see, how it compares to, people in a research setting. Um, but like I found that, people consider it a tricky thing to treat. People, OCD specialists will often refer out cases like this, um, because it seems to not be responding. So is it, a question of the provider? Is it a question of the treatment? Is it a question of the patient factors? Like, I don't know, like these would be great to know, and hopefully more research will be conducted on it. This is a plug to collect research in your own, or to collect data carefully in your own practice, so that you could have formal recordings of this. And this is talk to myself as well. I should be more formal and more systematic about data collection. So that's my New Year's resolution. Okay, so in terms of my own experience, let me just look at time. You said 9:15 is over, or how am I on time?
We have until 9:15, and you can leave time at the end for questions, so there's still plenty of time.
All right. Oops. Okay. So yeah, so family history of OCD and anxiety. Personally, history of generalized anxiety, social anxiety. So I mentioned the first time, 2011, I would say that was when I had that first situation where, I noticed it. And then there's kind of like between 2011 and 2020, like that 9 years, right? So what was that like? So I think, people who have this and patients who have this, they describe kind of like it's, so sometimes the beast will awake, right? And it's like, uh-oh, I'm noticing it again. And they'll get in a spell of it, right? And almost like it could really bring you down. And you're just having like a week or so where it's like really disruptive and really intense. And then kind of it'll calm down, like maybe something happened and you kind of were able, like you got very busy, and it would go away a little bit. But even when you get busy, you're kind of like worrying about when is it going to come back, right? It's just a matter of time before it comes back. So you'll engage in like this intermittent avoidance, right? Which is hard when it's something like swallowing. But I would definitely not talk about it. And when I wrote this article, like I didn't even tell people who I was very close with, because I didn't want them to ask me about it. Because if I'm doing well and they ask me about it, it could reawaken it. I was actually talking to a family member, and she's like, "Oh, I read your article." I'm like, She's like, "I never know you dealt with that." And I'm like, "Oh," and I explained why I don't really talk about it. And she's like, "Yeah, because I do a similar thing with the blinking." I'm like, "Oh wow, maybe we should have spoken about it." But it was like a form of avoidance, like the fear that you're going to, so like the fear that you're going to be reminded of it by talking about it and reawaken it, right? Makes you really want to keep it to yourself. Makes you want to, you can't avoid swallowing, but like you definitely don't want to, swallow too much. Or like meditation was very scary. Like also, with the breathing, like, am I gonna start noticing the breathing? So I think like you have this ebbing and flowing, right? And sometimes it gets really bad. And sometimes it's not there, but then you'll start celebrating that, oh wow, it's been a week since I've thought about it. Oh great. Oh man, like it's been a week since I've thought about it. And um and then you'll celebrate it. And then you celebrate it, and then you're thinking about it. So it's like really a mind F, if you will. So yeah, so it was like, thankfully, like there wasn't a tremendous amount of functional impairment. Um, so like I was able to manage it, but it was extremely distressing. But through 2011, um, like soon after it's 2009 I actually started, because 2011 I started grad school and it was before that. Okay, fine. But like, I was able to continue living my life. I went to grad school, I got married, I had kids, right? Like, um, so like even with it, I was able to live my life and have, thankfully, a good life. But like it was kind of like always in the background. It was like, and it would be really annoying if, like, you're going away on vacation and then it's like, oh crap, now I'm thinking about it, right? And that's like where the wishing compulsion comes in, right? Because and also the concept of like psychological flexibility. Very often when things are going really well, your psychological flexibility could go down, right? So you might be thinking, um, you might be thinking like, oh, I'm on vacation, I want to feel totally great, I better not think about swallowing, right? So it was kind of like a fly in the ointment when sometimes good times were ruined, specifically because your psychological flexibility went down in those circumstances and your sensitivity to it went up, because it has no space on your vacation, but yet it shows up. Okay, so 2020 was quite a year as well. I was doing a lot of virtual uh, treatment, and I got a patient who found me. Yeah, I got a patient who was very similar to me, and the patient was a therapist and had the exact same presentation of me, with the swallowing and everything. And it was, for whatever reason, and it made my symptom, like treating it and thinking about it, made it much worse for me, which was kind of, he was doing better, and at the same time I was doing worse with it. So it was a difficult experience, and thankfully, um, I think he did well and I did really bad. And it lasted for a while. Um, so I think from 2020 till 2023, I I would say like the values were a little, like it was just more intense, and lasting a little longer when it did strike, and that was really annoying. So like, and I would still engage in that avoidance, and um so I think, yeah, wait, hold on. Yeah, so like I think, like, if you think of the how to understand the severity of it, it's like how, just like any kind of symptoms, you have the frequency, intensity, and durations, and you can almost see, like, kind of like see it as a wave. And um in different periods of time, is how low does your, how steep does it go? um when how intense is it, during these periods of time? Okay. So, and I think potentially what made it challenging for me is I was kind of like frantically trying to use my clinical skills that I've honed in graduate school, to apply it to myself, and it wasn't working. So I was kind of freaking out. Or when it was bad, I was kind of freaking out. And then since June, maybe May, June of this year, the symptoms resolved. And I haven't had that. I haven't had them since. And I really want to caution that this is not like, this is how you cure it or anything like that. And I don't know that they won't come back. And I and I'll discuss like what I think may have happened, and also how it may inform both how we treat sensory motor, potentially other forms of OCD, and I'll elaborate on that. All right, next slide. So first, before I do that, I have like a theory on why, so a lot of clinicians say this is like a particularly difficult form of OCD treatment, or a difficult presentation to treat. It could often be comorbid with a lot of other things as well. But my theory on why it may be difficult to treat, one is based in prospective memory, and one is based in what I just made this up, like ameliorative motivated acceptance and values motivated acceptance. Okay, so prospective memory is memory of intentions, and it facilitates perceptions. So this was my first research, either my first or second research experience in undergrad. Okay, so this is 2010, July, and this was a poster or a paper presented at the Third International Conference on Prospective Memory in Vancouver, Canada, which I assume all of you were there and heard. But basically, we see what we intend to see: prospective memory and perceptual facilitation. So what's prospective memory? It's memory of intentions. So like maybe I need to mail a letter. Like I didn't pay my water bill, and I know if I, put it in the regular mail, then it won't get there on time. So I have to find I have to go to the post office and put it in that big blue mailbox because that goes faster that one. So like maybe walking around, and like even if I'm not necessarily thinking about it, would I be more likely to perceive a mailbox, right? So basically, the research showed that when we have ambiguous stimuli, if we have an intention to do something, stimuli related to that intention were facilitated to kind of notice things that are related to our intentions, right? We'll more likely see the mailbox. So in the course of the experiment that we did in college, we artificially embedded intentions into the research participants, and basically gave them this task where they had this ambiguous or basically like this blurry image, and the blurry image was related to the intention we embedded. I think it was like, please put, I think it was a letter, like they had to put the letter in the mailbox in order to get their credits for the research participant study, because that's how all research is done is on undergrads. Okay, so basically we then show them a screen. So they had this intention, and it was a picture of a mailbox, and it was totally blurry, and it became increasingly clear that it is a mailbox. And we timed at what point, like they had to push a button, and at what point did they notice what it is? And we found that individuals who had a prospective memory, which is a memory of an intention, their threshold for like noticing things is much lower, right? So I think, this is pretty applicable here, in that when basically all of, getting back to what I mentioned before, like we're integrating millions of bits of information all the time. And the ones that we notice are the ones that are important for us, like based on our intentions, right? Like, and, based on our motivations. And so I think when we go into therapy to treat our sensorimotor OCD, we get a new intention. And that intention relates to our blinking, and it relates to the swallowing, or whatever it is. And I think, when that is the intention, our threshold for noticing it is going to be lower. And I think you're just going to notice it more. Right? So ultimately, you're paying the therapist money to not notice it anymore. And you wake up wishing it wasn't there. So there's so much intentions involved with its absence. So I think we're just going to notice it much more. And I think it could be related to this perspective memory idea. So that's just one theory. So then there's this idea of acceptance. Wait, hold on. One is ameliorative motivated acceptance, values motivated acceptance, right? So as the word suggests, like people will accept something so that we could feel better, right? I accept not feeling terrible about this, um, for the sake that I don't have to feel terrible about this. And I think a lot of times, people like therapists talk about acceptance of various things. And acceptance can mean one thing to the therapist and mean something very different to the people, sitting on the other side of the room. And when it comes to this, like the idea of acceptance, oftentimes it's mistaken for acceptance of the symptoms, right? And even when you clarify, no, it's not acceptance of the symptoms, right? It's you're accepting that, in life there's going to be, you'll feel various forms of discomfort, and you accept that that's the case, such that you could, live your life, right? And you'll clarify acceptance is like being non-judgmental, right? We are just saying it is what it is, right? And then move, and which allows us to move on from there, right? So we have potentially ideas of what it means, but like when it comes, what they hear, like here are some things. If I could only find that acceptance, like that right acceptance, my sensory motor will be gone, right? Or if I find that, like almost it's like this thing that they're looking for, that like I need to do this cognitive magic trick called acceptance, and if I do it right, I'll feel better. And and we say like it doesn't work like that. And they may not feel better even when they say they've accepted it. Like I accept that it's there, but it still feels terrible, right? And I really want it to go away. And it's true, they want it to go away, right? So like, what does acceptance like mean in a therapeutic context? And I think what's challenging is like, how can you accept something so painful? It feels impossible. Like, I can't even think, how can I really do this? And it also feels disingenuous and it feels unacceptable because it's very painful. So like, what does acceptance really mean? So I think that's what comes up a lot. And I think, in many, in various forms, and I think sometimes a lot of people have challenges with acceptance-based treatments because this is the kind of feedback they hear. I still find it's very helpful, but I think I'll shortly discuss like how to make it, particularly helpful, in my opinion. Okay, so it's kind of like this idea of values-based acceptance. So values does not mean feeling better. You may never feel better, right? What can we make life about so that even if you feel terrible, and this is going to sound like a little extreme, but I think like acceptance, like people say radical acceptance and throw it around, but radical is a word that means that's like a big deal. It's radical, right? Like what does it mean to be radical? Like when you say someone's radicalized, right? Like they're so intense, right? So we're saying radical acceptance because the concept of acceptance is pretty radical in nature. So, and it's like radically accepting that this might actually never get better, right? And that's something that could be a lot to sit with, right? We don't know, right? We're not saying it definitely won't get better. We're not saying it definitely will get better. We don't know what the future is, right? We know what we've been through and we know what we're feeling, right? And we're kind of just saying like, I am accepting that this is the case right now. and I don't know what the future is, right? And I'm accepting that right now this is how I'm feeling. And then the next step is like, what can we make life about so that even if you continue feeling the worst, it will still be worth living, right? So like I think this is like the language of DBT, like building a life worth living. Um, people experience all various forms of suffering and and various forms of pain. And you want to say like, okay, let's acceptance is very much like, okay, it's a given. It's a given I'm going to feel terrible forever. Right? So whatever I'm going to make my life about, it's got to be so like awesome and so engaging and so worth it, so worthwhile that even when I feel terrible, like maybe that could be okay, and I could feel terrible, right? And I could experience these various symptoms because what I've chosen to make my life about makes it worth it, right? Um, and only then, in my opinion, can you possibly accept something like whatever it is, whether it is sensory motor OCD, whether it's OCD, depression, anxiety, whatever it is. And I want to totally validate that, having various symptoms itself can make it very difficult to even envision what that might be. You could be feeling very, very stuck and very, you're just trying to get through the next hour, like, let alone think about purpose and value and meaning and all these like lofty ideas when you're just like, I can't move. So I think like that's an important thing to totally validate. And that's why, that's why you have therapists to like help them get from that point where they feel like they can't move to where they're, working their way up Maslow's hierarchy and they're working on self-actualizing. Right. So so I think like when I say like I feel like my condition has improved, like we're having this discussion about sensorimotor OCD, and it's going to be like on video. And I talk to people about it, and now they start talking to me about it. And in working on my personal purpose, um, I I like got to a place where I say even if it does come back, like I don't care, right? And that does sound pretty right. Like, what do you mean you don't care? Like you felt awful, right? Like, yes, I know, but like I've kind of started working on the bigger thing such that it's not as important to me about whether or not I'm noticing my swallowing, my blinking, right? I'm okay with that. And I think that's what acceptance meant for me. And I think I found people have, resonated with that idea that basically like we're not accepting for the sake of feeling better because that seems to not work because just, that's what they call an act like the dead man goals, right? Like or like I'm not to not feel anxious, right? Like it's called the dead man goals because like, when you're dead, you don't feel anxious. Um, so it's not so worth it. Like when you think of like, oh, what's going to be my real goal is to be comfortable, right? Like that's a totally understandable goal when you're not comfortable, right? Your goal is to feel comfortable. However, when the goal is comfort, especially in the context of sensorimotor OCD, like it becomes very, like you end up noticing it way more because it becomes your goal, right? And when that's your goal, you just notice it way more, right? Maybe because of the um, perspective memory idea. So so I think that's what it means to me, right? So then you're kind of left with like, okay, how do you do that? How do you find that? What's that process look like? And I think it's not like so, I think ACT does a really good job on discussing these things. And but I think in my experience, like I think I may have like misapplied ACT, or like maybe didn't understand it fully, what it means by values, right? Because like, in the values bullseye, right? Like, so you have, let's say, your social life and your work life and your education life, right? And it's kind of like these, and you have the values checklist. And these are just things that are that, you have the bullseye, and if it's outside the bullseye, you're living far away from your values in that category. And if you hit the center, then you're totally living your values, right? So let's say a value of mine is family, right? Being a good dad, uh, being a good husband, which I'm saying is my wife is putting the kids to bed all alone. She's great. But like, those are my values, right? Um, that is a value of mine, right? So like, I would say, like, as far as the arrow, like, okay, like I'm close to the center. But these are kind of like more general values that many of us share, and they're kind of like, I maybe consider them generalized values, and I think that could inform things that are more like maybe higher values or more like mission driven values that are going to be based on like your core set of values, right? So and I think your core set of values will inform, it's going to inform the, what your mission is going to be, right? And again, like, maybe I'm saying things that sound a lot like I don't know, like a motivational speaker on late night television. And if I do, I apologize. But I think, sometimes things become cliche for a reason, because, sometimes there's a lot of truth to these ideas, right? I think like, they get passed down for a while because it resonates. And I think like we all intuit to some degree that, we're here for a reason. Like, that we're going through these motions and living our lives, but like, we want it to add up to something. We want it to be something. We want to stand for something. And I think ACT has a really good activities for this specific thing, which is like, what do you want written on your tombstone? And in the ACT values manual, you'll have, fill out your tombstone. You know, but even with that, I was thinking like, kind of like more generalized values. And then there's the activity of writing your retirement speech. Like, someone's giving a speech about you at your retirement, and your job is to write the speech for that person. And then I think that's a pretty awesome exercise, because um it really could tell your story of why you're being celebrated, right? A lot of people retire, right? But for someone to like have like a big gala celebrating your retirement, maybe you did something really important that changed a lot of people's lives, and is worth, so you're imagining that, and you want to make it very, very specific, right? Because like, you don't want that speech to just be like, he's a jolly good fellow. You want it to be like you did something, and they have things to say about what you did. And even thinking about what you want those things to be does help you get the ball rolling and thinking about that. And I kind of, in thinking about finding meaning, you kind of think of like the OG in Viktor Frankl's work, Man's Search for Meaning, something that gets people into becoming a therapist in the first place. Very impactful for me as the son of a Holocaust survivor. So he talks about, how meaning, uh, meaning is the central motivational force of life, like meaning finding. And to the extent that he was kicked out of the Adlerian psychoanalytic group because they didn't believe that was the motivating force of life. So I guess they had pretty strong opinions about that. But he found, that meaning finding was really a powerful force in people's life. And he had future goals. So Frankel also held on to the hope and goal of lecturing about his experiences after the war and sharing his observations about the role of finding meaning in the face of suffering. This future-oriented thinking kept him focused and future-looking, right? So, so very often, yeah, so this idea that he was going to, really use, and it's kind of meta because like his whole thing is that, if you could what's it called? If you have your why, you could get through any what, right? And finding your why is extremely important. And his why was being able to, survive, the camps, which is like the greatest form of suffering or the greatest form of torture. And he was able to get through it because he had really something that was bigger than him. It was like kind of transcendent in a way, which helped him push forward. And he ended up being successful. And it was like really one of the best-selling psychology books ever. So, he was able to achieve that goal. But I think there's something transcendent about it. And I think like that's like an extreme example, but like acceptance was that he was accepting that his situation is so awful and dire and torturous, right? And he accepted that for the sake of his life purpose, and that got him through a terrible thing. And I think that's like true with a lot of psychopathology to various degrees. I think it could be an extremely helpful metric, or like a very helpful way to deal with something. And I think for me, that's what I found, like in terms of purpose finding. And in my article, I didn't really discuss what my finding was. And hopefully, over the course of my life, it will become, hopefully people have something to say at my retirement dinner. That's my hope. But I want people to think that there's something unique about like the purpose that I've found. And I'm sure that is going to evolve and change as things change. I don't want to think there's something about the content that is meaningful for helping, but I think it's just identifying one's own purpose and that discovery and acting on that and trying it out and seeing if it actually is working for you, or worth suffering for. And I think that's really the way to go. So I'm going to talk now a little bit about maybe the process at which people could, I assume people think about it, but like to start thinking about it, because I think like in the ACT model, they try to move away from the medical model of mental illness. Like you have these sets of disease and we're going to fix that disease. And, so in ACT, it's like we're all in the same pot. We're all struggling. All our struggling is unique. I'm struggling and you're struggling. Everyone in this call is struggling in different ways. I'm climbing my mountain. You're climbing your mountain. My advantage as a therapist is that I have the advantage point of being able to see you climbing your mountain and the struggles you're having. And I have the experience in helping people, get through what they're struggling with. Okay. So yeah, so I think that ACT really does a great job at capturing that, so that the focus is less on just like how could I become comfortable, because when that's the case, it's very difficult, and instead it is about what am I going to make my life about, right? What's going to be my story? Okay, hold on. Okay, so okay. So finding and living your values and mission. So I like the idea of trying to be specific, and you want to be very honest, right? Because I think sometimes one of the roadblocks to finding your own personal purpose is lying. And I don't mean that in the like actually saying a big lie or something like that. But I think we all lie all the time, both to others and ourselves, as just something that we do, right? It's how we get along. I think it was Adler who called it lies of living, right? So like, our partner may ask us when we're coming home from, I don't know, from drinks with a friend, and we'll say 9:30, right? Like we know it's not going to be 9:30, right? But we just don't want to say 10:45. I don't know, right? So that's just an example. Like we will, sometimes very small, sometimes twists, tiny little, things that we say both to others and to ourselves that I think make it very difficult to be to like go on this journey of purpose finding, because like it takes a lot of honesty, because sometimes, you know one of the reasons why we lie to ourselves is it helps us keep forward motion. It helps keeps the wheels in spin, right? So like let's say you know uh you're in a career that you don't really like, um and I don't know, so like you could say like, this is a career that I don't like, but I need to do it because, even if I don't like it, that's okay. Maybe in the future I'll have a different career, but I need this for now, right? So that's one example of being honest with yourself. Alternatively, you could say like, you know what, I love this career, it's great, um and this is exactly what I always wanted to do, right? And therefore, like, so in the former situation, you may, you know, go on to do something differently without being erratic, because you were honest to yourself that even if though I don't love it, this is what I need to do for now, right? But in the latter situation, you may never know that you didn't love your career, because you're kind of weren't so honest with yourself. So I think honesty is just like a very important uh, thing to consider when you're mission finding. Okay. So in terms of like a very basic formula, I'm sure someone else has said this, but I don't know who. But like you kind of just think of like what makes you unique and what do you want to fix or change in your environment, right? So we're all unique. We're all special snowflakes. It's true. Uh, but we are by definition very unique. No one else has our DNA except for our identical twin. But we were all. But even in that case, we're all born in a certain environment with a certain family. We learned different things. We have different skills. We were exposed to different things. Like everyone's going to be very unique from one another. Even if you're born into the same family, like you're going to be different. You look different. You sound different, right? So you're going to be a unique person. And I think that also takes honesty, because honesty means like you're able to look at yourself and say, this is what I'm good at, and this is what I'm not good at. This is what I have working for me, and this is what I don't have working for me. Right. So like you're able to understand what makes you unique, um, because you're honest with yourself, right? So you're taking what makes you unique, and then you're also in a context, right? You're in an environment, right? And it could be your family environment, it could be your community environment, it could be in, I don't know, your country environment, like whatever it is, right? It could be in your work environment, right? You're all in environments, and you have desires, right? And you have things that you think are wrong. Like this world is very far from perfect in infinite amounts of ways. So there's no shortage of things that you could point to as wrong. or things that like uniquely bother you, and you talk to your friends about it, and maybe they don't get why it bothers you so much, but it bothers you so much. And I think that's very meaningful. Like, what keeps you up at night? What excites you when it improves, right? So like you kind of identify that there's something you want to fix or change in your environment. So you're taking like, and that also takes honesty, because like you can't rationalize things and say like it's all good and there's no problem there. Um, because that's one way to get by, because it kind of takes away the burden from yourself of making changes that seem impossible, right? But what you don't want to do is not be honest with it, right? So honesty with who you are, honesty with the environment that you're in, right? I think will help inform you of what is going to be your specific mission and purpose, which is informed by your values. And this was kind of really summed up by a video of Abigail Schreier, who discussed standing up to fear and reclaiming your freedom. So a clip of it. Hold on. Okay. Tell me if you're able to hear it, Donna. Okay.
Not the times when I obeyed the algorithm, like the 3, which I realize makes me very old to many of you.
Right.
But not so long from now, we'll wake up and be 43 yourselves. And when I look back on my life thus far, it occurs to me that the decisions of which I'm most proud, the ones that strike like an unexpected kiss,
Oh, wait, hold on.
not the times
One back too far.
of the pre-approved chorus will slide away as though you were never part of them. You will, each of you, have the chance to matter. You will find yourself at hospitals or in banks or in courtrooms and at newspapers where you will see things happen that you know to be wrong, where you will find that the standard line is actually a lie. You may have found yourself there already. If you're fortunate enough, you may even find yourself one day with children of your own, knowing that you are their best defense in this world. And you'll feel the nub of your will pressing you to do something, say something. And when that happens, don't sit there like a sock puppet. I'm 43, which I realize makes me very old to many of you, but not so long from now, you'll wake up and be 43 yourselves. And when I look back on my life thus far, it occurs to me that the decisions of which I'm most proud, the ones that strike like an unexpected kiss, are not the times when I obeyed the algorithm. They're the times when I defied it and felt for a moment the magic and power of being alive.
All right. Are you able to see my slides?
Yes.
Okay. So, in that, and I could, it'll be in the slides, and the slides will be available, but that 30-minute clip was her talking at Princeton about a journalist. She was a journalist, and she is a controversial figure, and I recognize she's a controversial figure. But I think what I wanted to extract from her talk is that she did something that she was really afraid to do. She identified something with, something that she felt was not going right, which is the care that was being given to trans-identified adolescent youth. And she wrote a book about it. And, it was a very controversial book, and they tried to ban it. And even the ACLU tried to ban it. And, but she believes in freedom of speech, and she reported it, and she tried to report it well, right? And whatever you think about the topic, whatever you think about her, or whatever you think about the book, I do think that the idea is that, she in her life identified a problem, identified, she identified that there was something that, was right, and she felt the pressure to not. And I feel like she had honesty, and I think she was able to do something that, that she believed in. And she described how, like, that's what makes you feel alive. And, everyone in their own life, I think, wants to ask, like, what is it in my world that I find challenging? What in my world do I find, you know, is wrong? And I think, so this is like a very big picture type thing. But, I think what's helpful is sometimes, like, when we think about treating various conditions, like, there's all these different types of discomfort. And, we think about how to get rid of discomfort, right? Like, we use measures of, like, how to reduce, how much anxiety you have, and we got to get that number down, because then that's successful treatment, right? But sometimes discomfort is what's needed in order for you to find, what you're going to make your life about, because life presents discomfort so that you could grow. Similar to what is it, the hermit crab? Like, they start growing, they feel uncomfortable, and that's when they know it's time to get a new shell, right? So, just in terms, so while this started like as a talk about sensory motor OCD for me, and this was, not only just like similar to other forms of OCD, but it's part of, like, the picture of human suffering that doesn't make me unique, or, because we're all experiencing that in various forms. And while there is specific tools that we CBT therapists have and evidence-based therapists use to, to work with this, I think you never want to lose sight of the why, of why we experience various forms of discomfort, and what are those pushing us to do? Because sometimes even within our discomfort is, therein lies potentially your meaning. And I think there's, like, a great quote that says, like, where the fear is, therein lies your meaning, or something like that. I definitely butchered it, but I'm not. Yeah. So I think I'll take questions now, and thank you for listening. And yeah, happy to discuss.
Great. Thank you so much for sharing not just professional knowledge, but also personal information from the inside. I know I found it really interesting to kind of hear the scope from the specifics of it all the way to, really kind of expanding it into some of that values work and meaning. So I really appreciate that. I know as people are bringing in their questions or maybe formulating questions, I have one. Um, I remembered once upon a time I got concerned about kind of like the floaties that you get in your eyes, like the sunspots, and it was one of those things. Okay, let's just go to the eye doctor, have it checked out. And I'll never forget. She said, I was like, so should I be concerned about those? And she's like, no, it's kind of groovy. It's like you've got these new friends that'll be with you for the rest of your life. And I thought, wow, what a cool reframe that was. Now as through an ACT lens and acceptance and commitment therapy lens, I was like, oh, this little diffusion right there, like right off the bat,
Yeah.
which I thought was kind of neat. And I still think about them as my little friends that travel with me everywhere, with varying degrees of focus and attention at different times. But one of the things that it made me think about is that aside from our parents, medical professionals are sometimes our first avenue of noticing bodily sensations, and we're kind of taught, like, notice what's wrong. And now we've got a whole internet that's full of notice what's wrong. And, everybody's Googling their symptoms. And I wonder, what's kind of in early points of entry to build, perhaps a better relationship with teaching, even just young kids, like just how to notice with some neutrality, so that it's not always, oh no, when we notice things, but maybe, oh wow, or at least something more neutral, like, interesting. Is there any how can we build this at kind of a young age and build maybe some of that curiosity and neutrality, and is there kind of a point of entry maybe for medical professionals to work within that sphere too? Some thoughts.
Okay. That's a really interesting question. Let me think. Okay. So I think even recognizing that as a value is a very important first step. That I think sometimes parents like have, they say like the kids of psychologists are gonna all be crazy. But I don't know if that's true, because I feel like sometimes you really learn great things about parenting and about the human condition. And I feel like as long as like what helpful parenting is and how you help your kids navigate their own pain is going to be like the most important lesson in life for them, just like it is for ourselves, right? So, there is. So you just described a very helpful skill, like the idea of diffusion technique, right? And I think that could be, taught well to kids. And I think also like getting to the big idea, you're helping them realize that there's something bigger, like with the various challenges that they're experiencing, like you're also helping them orient themselves to things that are bigger, right? Like, do we talk to our kids about values, about charity, right? So for example, yeah, so like when I was a kid, I used to collect bottles with my dad, not like from other people's garbage, from like our own garbage, but like we always used to collect it, and then we would, we would go to the machine and deposit the bottles, and we get some money, and we'd buy ice cream with it, and we'd also buy a book, right? So it's like this idea, so I just started doing it with my son, and yeah, it's this idea like we're kind of giving them values, like we're kind of really helping them realize there's something bigger than themselves, like the idea of charity. And I think helping people focus on others' suffering and other people's challenges takes a little less focus on your own challenges. And not saying that their own challenges don't have to be addressed and helped, and every situation is going to be very unique. But in terms of like a general approach, like helping them like learn to accept for the sake of something else, right? And I think that's a super important skill. So it's a great question.
Thanks. That's a great answer. We also have a comment from one of the attendees. I just wanted to make a comment. I treated a young woman with OCD initially for her fear of choking following a choking incident. The fear of choking evolved into hyper awareness of her swallow reflex.
Yeah.
Not a question with it.
Oh,
You can kind of, I guess you're just looking to comment on it.
I
Wonder
love
if you
comments.
could kind
Yes.
of branch into that sensory motor OCD.
Yeah, and I think that's a great example of the acquisition, right? Like, where did that initial pairing come from? So it's like, oh, like I had the situation where just swallowing, the experience of swallowing and noticing swallowing was paired with a near-death experience. Oh, wow, I better focus on swallowing, right? And then that itself. So that makes a total sense, and a great example of pairing. And I think that sometimes, like CBT therapists are very focused on, like what's going on right now. And we don't necessarily pay so much attention to the origin story, because ultimately, an origin story is not falsifiable, in the sense that, especially if you're like talking about older origin stories, right? Like why do I do things that I do? And then I could come up with like a big story about, involves my parents and involves it, right? Like, and that's why I am like today. And that could be very, very meaningful, right? For someone to have like insight and to create insight. But it's not something that we know, right? We don't know why why you do what you do or why you say what you say. Like we could come up with theories, but there's no way to disprove them. So ultimately there are theories and we make meaning of them. But sometimes like there are situations like this where it's like so clear the origin with the with the the manifesting symptoms. Another example is I had a patient who had a fear of her child getting diabetes. There was no family risk of diabetes or diabetic symptoms. And whenever the child asked for water or like seemed to have a dry mouth, like that would be symptoms of diabetes in a kid. That's what I learned. And I really think like, when did this start? She's like, oh, like my son had a friend who I correctly identified had diabetes. I'm like, okay, I think that might be where it came from. So yeah, so that's a great origin story and a way it could be helpful.
She actually had some other comments I didn't see because she had hit enter, but she had also written, just to follow up with it, we use EMDR to install the thought, quote, my body is designed to take care of itself, quote, my body knows how to swallow, quote, etc. She reported that it was very helpful. And then if she asked if you had any thoughts regarding that, which you already shared some thoughts on the CBT end, but I guess she wanted to know if you had any thoughts on the EMDR.
Yeah. So, like this idea of well, first of all, it was helpful, right? So, therapists know some things, but we don't know a lot. And if you had a situation where what you did was helpful, that is awesome. I don't know about so much about the research of EMDR for OCD. There is questions about disentangling the various aspects of a treatment in terms of identifying active ingredients. Some research is potentially showing that the bilateral stimulation could be a meaningfully helpful component. But as you mentioned, like there's also the cognitive component, and then there's also the exposure component, and like what's causing what change. Like I don't know. But I think EMDR has important components to it. I just don't. Yeah, and it sounds like it was helpful. I don't know what part of it is helping what, and I think that's when you're thinking about treatments. I think you want to think of like what's the active ingredient, and so I think that's one of the question marks. A lot of people find it like super helpful, so it sounds like it's working for you. So
we have another question. Before I give you the other question, I just want to let everybody know that after this is over, you will be emailed a CE Google form to fill out. That's an evaluation form that you have to complete in order to get the continuing ed credits. And next month we will have a workshop, but it is to be determined. So just keep an eye on the listserv or our Facebook page and you'll be able to see that. We have another question. Would obsessional staring be a form of sensorimotor OCD? For example, I'm working with a client who reports that he stares at particular things due to a fear of forgetting things. What would be some good response prevention for obsessive staring? And then he also says, thank you for this great presentation. I also appreciate that discussing this topic could be great exposure for you.
Oh, thank you so much. So there is this Facebook group called, so staring compulsions is not uncommon. I mean, it's not common. What am I talking about? But it exists. And there's a lot of people in a Facebook group called Obsessive Staring. It could be a very difficult presentation, right? So like, so there's the structure of the OCD and then it gets filled in with various it has this like superficial structure, but that has implications what that structure is. So if like you have a compulsion where there is this form of compulsive staring where you actually fear that you're looking at someone's genitals or breasts or something like that, And sometimes you'll do a checking compulsion and actually like stare at people's genitals, right? Like, and like, you know, so sometimes people will lose jobs. You know, it's a very difficult presentation. What you were describing, am I able to see the questions or just?
There, if you hit the Q&A
Oh, I see. Okay, cool.
for you.
I just wanted to make a okay, there we go. There you go. Okay. So basically, in that specific, what was the specific part of the question?
I'm working with a client who reports he stares at things due to fear of forgetting things. What would be some good response prevention?
Okay. So it sounds
Or
like
ways
there's
for
that might be more of there's a memory hoarding type OCD where it's like I need to keep everything. It might be more like that. Obviously, like this is when you ask a specific case, like very often like OCD questions, you'll have like a specific case and the question is what's the exposure for it? I think what you're gonna really want to get very good at is doing like this holistic like functional analysis and then you know having exposures as one of the tools that's going to treat a part of that. So but what you're describing sounds potentially more like memory hoarding where like they're making sure they have information and there's a lot of compulsions pertaining to forgetting about things, and then one of the staring might be specific to like messing up the memory hoarding. So it might be a case where like the exposures need to be related to distracting the memory, right? Or like helping not encode things and being okay and living with the memories that we have. So basically the answer is do a good functional analysis and understand how exposure works within that plan.
Great. Thank you. So I echo what everyone has said about thank you for a wonderful presentation. I don't see any other questions now. So again, thank you for giving us your time. And for everyone who had asked, I believe that Dr. Kamenetsky had also said, you will get a copy of the slides of the presentation. So we will send that out after, along with the Google form for continuing education. So thank you all for attending tonight. And again, thank you, Dr. Kamenetsky, for coming and speaking with us and sharing your time. And people are writing in. Thank you so much for such a thoughtful presentation. I echo that as well.
Thank you so much for having me. This has really been a pleasure.
Saying thank you for a wonderful presentation and for sharing your own experiences. And that is it. I am going to end the presentation. Thank you so much.
All right, great. Thank you.
Meet you. Take care.
Bye.
Bye. Thanks again. I appreciate it. It was nice to meet you.
Great meeting you. Take care.